Thank you, Peter. Thank you again for the invitation. Yesterday was absolutely a fantastic day. I actually learned a lot with a couple of discussions I had, and had a great meal, which was amazing. So thank you very much for the opportunity to be here and allowing me to speak to you guys about some of the work that we're doing. I don't really need to speak too much to this group about ctDNA, but I'm going to try to sort of bring the clinical relevance that we've been able to identify with some of the work that we're doing. I have disclosures, Peter, where they are. So these are my disclosures, especially the Natera one, because that's what we predominantly use as our platform, since we don't have an in-house platform.
But you said yesterday you had never used Urologic before.
I haven't used it, but I've been on advisory telling them what to do. I've not used it. Luckily, they don't care if you use it or not. So, I mean, again, no introduction is probably necessary, but what is ctDNA? So ctDNA, cell-free DNA, circulating tumor cells. These are all different terminologies used for the contents of either normal or tumor DNA floating into our serum or into our blood system. And again, it can be both normal cells and it could be tumor cells or tumor DNA. So both can be found in the circulation. And it doesn't necessarily mean anything in many cases because evolutionary, and this goes back as far as we can actually date it, the complement immune system actually degrades these contents. So there is a whole immune response that occurs, especially in the blood using the complement system that degrades and gets rid of these contents. And so that's why the half-life of ctDNA in the circulation is usually 1.5 to 2 hours because of this well-established evolutionary immune response that occurs. So that's something to just keep in mind and remember. And for many years, and again, great work that's been done at this institution, the idea was to really use this ctDNA, cell-free DNA, CTCs, as a biomarker or as a platform to allow us to make better clinical decisions. And I think at this point in time, we are now seeing that evolution occur. And I'm very excited about the future of these platforms and these different technologies because I do think it has clinical relevance. So these are the commercially available platforms. There's what you can call tumor-informed platforms like Natera, and that's what we use at Mount Sinai. And there's tumor-agnostic platforms, so platforms that already just have a library of mutations or known mutations that you could just plug and play with all the different cancers. I personally think that the tumor-informed are slightly better for bladder cancer, but there are roles for the tumor-agnostic ones as well. So this is, a review that we wrote a couple years ago with our current fellow, Ruben Van David, who spent some really amazing work with our databases and has established a really great pipeline for obtaining the information for us. And, we do think that from the standpoint of how we use it, that it's actually the TURBT specimen, so the initial specimen at diagnosis is the one that we can actually gain all the information that we need and allows us to then sequentially monitor the patients and then also be able to make clinical decisions based on that. So this is not something new, but if you do a PubMed search, and this is to 2021, and I'm sure 2022 and 2023 and so forth, the amount of work using ctDNA has skyrocketed over the last couple of years. And not only in GU cancers, and really in urological cancers, it hasn't really taken off yet, but in other cancers, it definitely has taken off. Cancers like colorectal cancer, ctDNA and Natera is actually in their guidelines. It is used to actually make clinical decisions, especially for adjuvant therapy in stage 2 cancers. You can see in Korea, and this is the sort of clinical guidelines for Korea, they have actually placed ctDNA in a lot of their recommendations. Organizations like ESMO has actually started to, based on level of evidence, make suggestions and recommendations that if you don't have X, you can use ctDNA, and eventually all that will end up, again, coming into the front line when we start to get more data. And you can see that here's urothelial for ESMO. So it is something that is recommended if tissue is not available. Again, the digital pathology, which we had some discussions about yesterday with a couple of folks, is the most important. But we are recognizing that ctDNA can be a tool that should be used. The initial sort of data, goes in, at least in the variety of cancers, really started in 2017, 18, 19. You can see it in a variety of different cancers, bladder being one of them. Small numbers of patients, but you see the green line on the top, and that's for the ctDNA undetectable or negative patients. Those patients prognostically actually do phenomenal. You can see a very high sensitivity for the negatives, and you can see actually for the positives a lead time bias before you actually can see radiographic imaging. Of course, the question to be answered here is if you can identify micrometastatic disease and we start treatment earlier, would that necessarily change the patient's outcome in the positive setting? Which I think that there are trials to be performed to answer that, but we're not quite there yet. And then, Julian's great work, 2021, really at the peak of where we started to see this work in bladder, really showed that there is a utility for looking at cell-free DNA, ctDNA in bladder. We can pick up the mutations that are the most common, the ones that we see in the tissue, in the serum, and that there is actually a outcome association, survival outcome, that can be identified between those that are detectable and undetectable. Around the same year, the sub-analysis for IMvigor010, which was a negative study, but positive in sub-analysis when you looked at the ctDNA positive patients, came out a couple years later on extended follow-up. Again, you can see that the ctDNA positive patients statistically had an improved recurrence-free survival with adjuvant atezolizumab compared to those who were just on observation. So the beginning of actually showing clinical utility and clinical relevance for ctDNA. When we think about it, and when I first sort of started looking into this and analyzing the data, to me, it really hit the point that we need this in our clinical trials. Because if we look at this group of patients in any Kaplan-Meier curve that we do, we know that this group underneath these curves does not need any therapy, in this case, adjuvant therapy, because it didn't benefit them. They did great with observation. This is the group that benefited and will benefit from further therapy. And unfortunately, this group is the group that's not going to do well. So could we use ctDNA in these clinical trials to really focus on the pink and the black group as a biomarker to be able to develop and quote unquote personalize the care slightly better? Now, of course, we need better therapies, or we need therapies that work in order to make that statement an accurate statement. And there are more novel therapies like pembro and so forth with responses that we really can work with. That's led to the development of IMvigor011, which is similar to 010, adjuvant atezolizumab versus placebo only in the ctDNA positive cohort. We have Modern, which is a study that's being led by Matt Gaske, who's with me at Mount Sinai, where there is actually both positive and negative groups. The negative is a similar study, but just using nivolumab, observation versus adjuvant. And the positive is actually escalation of treatment, which is important to actually cover the patients or the top of the curve that was in black when I showed you on the Kaplan-Meier by adding a LAG-3 inhibitor to a PD-1 inhibitor. And so these trials are all now personalized in a sense around ctDNA, allowing us to better identify, at least in the adjuvant setting and the advanced setting, the patients that we should be giving or escalating care to versus those who we shouldn't. From the urologist standpoint of view, the idea that came to my mind was like, this is great, but can we move this even further up? can we now start to identify which patients maybe we don't need to give neoadjuvant chemotherapy to? Maybe we don't need to do surgery, or we shouldn't do surgery in certain patients, because I'm sure we've all had those patients where we do surgery and then 3 months later they're metastatic, and it's like, did we really benefit them? And so that sort of data really started back in 2019 with Klaus and his group from Aarhus, who actually showed published this paper based on their trial, which was 68 patients, all with advanced muscle invasive bladder cancer, all got neoadjuvant chemotherapy, all had sequential ctDNA analyses, and then the outcomes of those patients based on the ctDNA outcomes was analyzed. And very interestingly, they found that ctDNA was a significant prognostic marker after TURBT before neoadjuvant chemotherapy. The lack of ctDNA clearance during therapy was a really bad predictor, so it was a predictor of worse outcome. And then, very interestingly, in this group, they had 100% overall survival for the ctDNA negative patients. And using a single time point, so a single ctDNA time point, either before neoadjuvant chemotherapy or after completion of neoadjuvant before cystectomy, you can see that those patients who were undetectable had the best outcome, with those being the patients in the blue, with the blue line in this Kaplan-Meier curve. And again, you can see the survival differences from a single time point going out all the way to 900 days, that those patients had 100% overall survival, the ones that were undetectable, from the same single time points. And for me, the shocking thing was that this was published in JCO with a hazard ratio of 129.6. I don't even know what that means, but that means that there was a strong correlation that was really impressive. Similar lead time bias of about 96 days. And then there was a more reliable predictor of lymph node status and worse pathological outcomes if you were positive compared to any of the clinical measures that we have today.
That's before surgery or after surgery? So
the time points, either before neoadjuvant or after neoadjuvant before surgery, they both came out almost simultaneous. So these are single time points.
That suggested that the ctDNA is of metastatic origin and not of primary tumor origin?
That's a great point, and I'll get to that in a few slides. So then all those patients were neoadjuvant chemotreated patients. The same group actually then had a group that was, they had a biobank blood specimens for patients who only underwent radical cystectomy, so no neoadjuvant chemotherapy. They compared the prospectively collected to the retrospective. So of course, there's some biases in this group, of course, of selection bias. But what they similarly found was that a ctDNA before neoadjuvant chemotherapy, a ctDNA sample after neoadjuvant chemotherapy before radical cystectomy, or for those who underwent radical cystectomy alone, Kaplan-Meier curves pretty much outlined with each other. So the blue and the red, you can see undetectable, had the best outcomes regardless if you got neoadjuvant chemotherapy or not. When they compared those head to head, again, you can see that the curve there, I guess. I don't know if you can see that, but it's better to do this. So the curve on the left here are the group that had neoadjuvant chemo compared to just cystectomy alone. No significant difference between the two, and those are for the undetectable. And then the detectable, you can see that they just do really poorly. Those patients don't do very well. So with actually Natera, there was a group of investigators in a couple of different institutions. There was about 7 institutions that pulled their data together, and we started to look at the clinical relevance of ctDNA, specifically Natera, in bladder cancer. And we looked at 3 different time points. So we looked at the pre-cystectomy time point. We looked at what's called the MRD time point, which is between surgery and 3 months. And then we looked at the surveillance time point, which is greater than 3 months, and that would be more the role of adjuvant therapies. When we looked at the mutational burden, similar to the group here and what Julian showed, we found the same mutations that we would expect, all the same sort of TCGA well-known mutations were identified, and the sort of status correlated pretty well with the mutational burdens. When we looked at the pre-cystectomy cohorts, so this is the undetectable versus detectable, similar to what Lars's group showed. The undetectable patients did really well, and our hazard ratio was not 129.6; it was only 7. But again, a pretty significant outcome when you compare in a multivariate to the known clinical factors, including the pathology. ctDNA at a single time point prior to cystectomy still did better than all the clinical relevant factors that we use in practice. And interestingly, when you actually looked at those patients who were undetectable, whether they got adjuvant therapy or didn't, so those are the two top curves. They, again, like in Vigor 011, the ctDNA negative patients did really well. The positives did poorly, but those who got adjuvant, which is the green line, did much better. And again, our cohort also had small numbers, but similar findings. In the MRD window, so that first 3 months, you can see that, again, the undetectable versus detectable, those patients the undetectable did fantastic with 100% overall survival, and a pretty significant, the ctDNA, again, in multivariant was significant for disease outcomes. So this was just the sort of test the waters, make sure that, this assay is just as good as what's been published, even though Lars's group used the same assay, made sure that clinically that there was some relevant there. And then we started to think, well, as a urologist, what do I want to know? When I'm counseling a patient, the question is, should I counsel you for neoadjuvant chemotherapy? Should we go straight to cystectomy? And the longer I've been doing this, the more I think I'm an expert, and the more I think I can make the right decision for patients, especially those patients who don't want neoadjuvant chemotherapy. Do I need to push them towards therapy or not? And there have been a lot of markers that have been attempted in the literature, things like ERCC2. I was part of the group that published that paper in Cancer Discovery, where we thought we found the holy grail biomarker. ERCC2 was going to be the marker that, allowed us to identify. So a mutation in ERCC2 would allow us to say, you are the patients that should get neoadjuvant chemo because you had the best response. Unfortunately, when you actually expanded the cohorts, it actually was a poor marker, because yes, while there was high sensitivity for the mutation, a lot of non-mutated patients also responded to neoadjuvant chemo. So you couldn't really use it as a sole marker to recommend chemotherapy or not. Tumor mutation burden, DDR mutations, we were talking about the RETAIN trial. The RETAIN trial used these DDR mutations because we thought that was really going to be the biomarker. Unfortunately, those trials didn't end up being as positive, or some would argue that they were negative. So we know that the DDR mutations are not perfect as well. And really, it's trying, the benefit is only 5 to 6%. I say only, clearly for a patient who has the benefit is extremely important, but the toxicities, all of the other side effects are important to consider. And so could we use, my thought is, could we use ctDNA now as a better marker to be able to help inform patients, share decision-making about who should or shouldn't go to neoadjuvant chemotherapy followed by cystectomy. So we started by looking at our group, and we established a protocol that every patient prior to cystectomy, using the TURBT specimen, would get a ctDNA analysis performed. And from there, we would do sequential, not necessarily change our treatment regimen, but just collect the data. So this is one of our first publications from last year, where we actually identified that about 50% of patients who present for muscle invasive bladder cancer actually have a positive ctDNA. So 50% of our patients will have quote unquote micrometastatic disease at presentation, and 50% won't. Interestingly enough, biology speaking, 21% of our patients who were undetectable were actually stage 2 or higher, and 10% were actually node positive. So this goes to speak to the biology of this disease, that there is or are some tumors that actually have lymphatic spread, but don't have any hematogenic spread. And there are some that have hematogenic spread that are the ones that are actually the worst outcomes. But higher stage doesn't necessarily mean worse outcome. And I'm sure we can share stories about, T4 patients that we thought were going to die and then are 5 years later and are doing great. And that might be this cohort of patients. And we do know that undetectable ctDNA, similar to what was presented before, is an actual surrogate of downstaging or stability of disease. So if you are undetectable, you're likely going to have less than T2 disease and do pretty well. When we looked at our pre-cystectomy patients, we can see at 12 months, if you were undetectable, regardless if you got cystectomy alone or neoadjuvant and cystectomy, you had a 95% recurrence-free survival compared to the positive patients who were at about 50%. So clearly, very important to be able to counsel those patients differently. When we look at our dynamics, we see that in the purple line on the top of the graph are those patients who got neoadjuvant chemotherapy with undetectable ctDNA, then went on to surgery, and the blue are those who got cystectomy alone. And you can see really overlapping lines, no difference in outcomes if you got neoadjuvant chemo, if you were undetectable. And then unfortunately, if you were detectable, similar situation, neoadjuvant chemotherapy doesn't necessarily help. The numbers are small for those cohorts of patients. There are probably that 5% that we would identify in the positive cohort, but the numbers that we would need to prove that would be pretty astronomical, and we weren't able to show that alone. But if you look at the 12-month recurrence-free survival rate, the undetectable patients were greater than 90%, and the detectable patients were between 30 and 40. So those are the patients that likely need escalation of care. And even if they get neoadjuvant chemotherapy and cystectomy, we're actually only curing a small number of those patients. So should we be doing cystectomy on those patients is really the question that needs to be answered. We do know that there are a cohort of patients, to your point, Warren, that are detectable, but then become undetectable after surgery. So that is probably those tumors that are shedding, but the immune system is likely dealing with that shedding, not allowing for metastatic disease to occur. And that's that gold line that you see in the middle there, that yes, there are patients that go from detectable to undetectable with surgery alone. Some of them will actually end up having a recurrence, but a group of those patients, we actually can have good outcomes if we take them to surgery. It becomes a little bit more complex identifying those patients and the biomarkers, but at least there is a group of patients that we can convert to negative with surgery alone. And that's an important group that we need to do better with identifying. But again, the undetectable do absolutely phenomenal, and especially those that remain undetectable. So detectable pre-cystectomy, undetectable at the MRD window. And then when we look again in a multivariate, we can see that the pre-cystectomy ctDNA is the best biomarker for patients' outcomes. And if you see just below the red bar, you can see that the MRD ctDNA is also really important. And it is better than what we use in our current algorithms of pathology and clinical factors that we see. So we then went to actually understand if undetectable pre-cystectomy or pre-radical cystectomy can actually predict outcomes. Can we say, if you're positive, you do worse. If you're negative, you do fine in a larger cohort with more follow-up. And in a larger cohort with more follow-up, same thing happens. The undetectable patients do phenomenal, whether they get neoadjuvant chemotherapy or not. The positives have about a 50% recurrence rate. And again, similar to the patients that are converted, they fall right in the middle. So if you're detectable before surgery and are detectable after surgery, you do really bad, you can see that only about 10% of patients are still recurrence free at 12 months, and those are the ones that are heavily treated with adjuvant therapy. And then the red bar, the red line in the middle, are those that we actually convert from detectable to undetectable after surgery. So a lot of work needs to be done in this cohort of patients. Likely will require other biomarkers in addition to ctDNA to help us identify really the ones that the surgery would benefit, and probably escalation of care for some of the other patients. Maybe not go to cystectomy after neoadjuvant chemo, maybe add in immunotherapy and wait and see if there is a decrease in the ctDNA. I'm not sure that's the answer or not, but I think that there's a lot of really important questions and a lot of great science that can happen in this group of patients that I'm excited about for the future. When we look at the interesting group of patients, which is the node positive patients, similarly, like I discussed before, in the pre-cystectomy undetectable but node positive, so that's the purple line, and then the blue line is the node negative undetectable. They do pretty much exactly the same. So this is, in my opinion, a group of tumors that only spread lymphatic, and if you can do an aggressive and good node dissection, you probably can help those patients. Similarly, clinically, we knew that this was always the case because we've all had, T2, T3 node positive patients that have gotten surgery, and some of them don't opt out of adjuvant therapy or just were too ill for adjuvant therapy. The time frame passes, but then they're alive years later. And I think this is the group of patients. And again, in the MRD window or in the surveillance window, we can see that they do fine. And those patients that were positive, that we converted to negative with surgery alone and node positive, do exactly the same as well. So there is more to this, I think, than just, is there ctDNA in the blood? There's a lot of biology within the tumors themselves that needs to be unraveled to help us better understand the biology behind the microenvironment and which tumors are spreading how, and how we can use all that information clinically to allow us to make better decisions for our patients. So the other question here was, and what we were noticing was that all our undetectable patients were doing fantastic. All our undetectable patients were just having great outcomes. So can we then think about getting rid of imaging? Do we need to do surveillance imaging on these patients, or can we just use this biomarker as a tool to allow us to then make the decision, should we or shouldn't we get imaging? This is a paper that we just submitted for publication. It is an abstract actually at the EAU. And we looked at about 100 patients who had ctDNA post-radical cystectomy, and we went and correlated it with the image findings based on the recommendation, the guideline recommendation imaging based on their stage and grade. And what we actually found was what we thought we would find, which was that there was 100% sensitivity. If you had undetectable ctDNA, there was never a positive imaging finding. If you were positive or detectable ctDNA, most of those patients actually developed a recurrence at some point with a lead time bias of roughly 3 months, and that just happens to be because that's how often we would get imaging. I'm not sure we can truly say what the lead time bias is because we have such a regimented surveillance that we would say 3 months because that's when it shows up. So I think that the ctDNA status here may be a surrogate and allow us to de-escalate how much imaging we're getting on patients. And I don't think it matters what the actual pathology or the pathological outcome is of these patients, because there is a lead time. We can just send the blood test. If it comes back negative, we just continue following without imaging. If it turns back positive, then we can escalate the surveillance with imaging and so forth from there. Sorry. And the nice thing about, at least with Natera for us, is that they do home tests. So our patients don't necessarily have to come in to see us. We just establish the home test. There's a blood draw that goes to their house. save some a trip, probably similar to Vancouver. It varies. I don't know. I mean, it's all there. Most of it is proprietary, but it's anywhere between 500 and 2,000. That's at least what they bill the insurance based on what they've. So we actually haven't. We've tried to do the cost effectiveness of this. I don't think it's going to be cheaper necessarily to do this compared to imaging, but we do save radiation. We save them trips to the hospital, to the visit, to the hospital system, et cetera, et cetera. So probably break even, but.
So it's offered you by Lifeline, $4,000 for the first test.
In the US, it's covered by insurance. Medicare covers it, and I think they bill out like a couple thousand for the first one, but don't get that, obviously. And then the next subsequent ones are, less than 1,000. So what does the future hold for pre-cystectomy ctDNA? I think detectable pre-cystectomy ctDNA is definitely associated with a poor prognosis. We can now start to substratify subgroups based on the actual burden, based on detectable or undetectable, based on if they have surgery or don't, if they have chemo or not, and what the actual what the conversion is of the DNA based on the therapy, and then allow us now to have better algorithms in terms of how we can, what recommendations we can make for our patients, how we can move forward with treatments, et cetera, et cetera. The bigger question is, can we actually use ctDNA as a quantitative measure? So here, all this data that I showed you was positive or negative. But are there cutoffs? Because there are actually there are values that are associated with these tests. So can we now identify a cutoff, whether it's in combination with other clinical factors or just the ctDNA alone, to be able to help us make those decisions? The subgrouping obviously lead to better oncological outcomes, which is the goal of all this. And I'm not sure that we are quite there yet. For the last point in this slide, I do think that we're getting there with therapies like EV Pembro that are having so much better responses. Maybe we will actually be able to truly identify the patients that need the therapy earlier on, and be able to bring better oncological outcomes. But we'll see how that goes. So the test report does give us this MTM per ml. So mutations per molecule per ml of serum that they receive. And then there's an absolute number that comes with it from 0, which is undetectable, to as high as hundreds that I've seen in some of our patients. So we took all the data that we had in our 130 or so patients, 120 or so patients, and we tried to look at the values and maybe establish a cutoff. We did a AUC and ROC trying to really establish and at least stringently statistically identify a cutoff, and 2.5 MTMs was what we came out with about an 80% sensitivity. So not great, but not bad. And so then when we looked at the undetectable patients, which is the blue line, compared to what we call the low burden patients, so those with the pre-cystectomy sample that had a 2.5 MTM per ml or less, that's the red line. And then the yellow line are those that actually had higher than 2.5. So the Kaplan-Meier curves do separate pretty nicely. So the pre-cystectomy, or the actual absolute value prior, using the TRBT before making a treatment decision, does actually have a correlation with outcome. Now, I think with time this may get better, but this is what we have so far. We use recurrence-free survival. We don't you mean overall survival curves. A lot of our patients have not, have recurrence, but have not passed away, because you can see our follow-up, our median follow-up here is roughly 1.5 years. So we need more time for that.
That's
So in this patient population, the advanced patient population, we go at every 6 weeks. Pretty reliable. Yep. There's the only time it's not reliable is when there's, in some cases, there's not enough tissue. They'll come back and say, not enough tissue to do the sequencing. So that's the only issue. Yeah, but I'm sorry. It is, yeah. So the only time it becomes an issue is when the initial, whatever specimen you send doesn't have enough tumor cells to get like the enough DNA for the whole sequencing. But once you have that, then it's pretty reliable every time. And like I said, that's where the imaging outcomes come to play, because we actually saw that it's almost 100%. It is 100% sensitivity. Undetectable is undetectable. So there is a question of doing better tests, more sensitive tests. Can we pick up even lower levels of plasma DNA circulating if you had better markers or better platforms to do the test. But this platform, I think, works very reliable and very good with clinical relevance. And that's, I think, the important part, that there is relevance clinically with what Natera has put together and established. Some did, some didn't. Yeah. Not enough patients for us to start breaking it down. But yeah, and some had neoadjuvant, some the only ones with cystectomy, et cetera. But overall, what you see is that high burden pre-cystectomy has the worst recurrence-free survival. You can see that the high burden, the 6-month recurrence-free survival is 42%, with a time to recurrence of 5.2 months. So now we're finding the worst of the worst players, even in the cases where they got neoadjuvant chemo, cystectomy, adjuvant, or no adjuvant or adjuvant. A lot of these patients recur if they have a high burden. And it may be a little misconceiving because it's 2.5 here, but you have patients who have values in the hundreds, and that those patients are just, even though they're not metastatic on imaging at the point in time, those are the worst players. And even after neoadjuvant chemo, I'm not sure if their ctDNA is not going down. I'm not sure that those are the best patients to move forward to cystectomy. It may be better to just try to give some systemic therapy and try to really attack the micrometastatic disease before surgery. The low burden patients do really well. They do almost as well as the undetectable, but they do have a recurrence, and that is the late, quote unquote, almost like the late recurs out to about a year. And then again, the undetectable pre-cystectomy patients just do fantastic. So I'm going to switch gears for just a few slides, and then I'll come back to this, because it is important to identify that at least in urothelial cancer, there is a tumor agnostic platforms. So these are the platforms that have a mutational library that they've established from identifying the most common mutations in cancer, period. So you can make libraries from 100 to 200 to 300, as many as you like. I think the Guardant one here has about 100 or so mutations, but don't quote me on that. And this was work that was done by Roger Lee, actually using the upper tract samples, right? Because upper tract urothelial cancer, at least for the urologist, becomes a challenging, and has always been a challenging diagnostic disease, because we get these small biopsies. A lot of time, those biopsies can be inconclusive because our pathologists just don't have enough tissue to tell us the grade, the stage, et cetera. And so using this platform, which doesn't require any tissue, all it requires is a blood sample, it allowed a better risk stratification of the upper tract patients, where you can see that here is the muscle invasive group patients. The Venn diagram down here does show that there's an overlap between the mutations, most of them being positive in the muscle invasive bladder cancer patients. So when you look at the swimmer's plot here, the bottom is the muscle invasive, the top is the muscle invasive, and this was at the time of nephroureterectomy. You can see that the dark triangles were those patients that actually had positive ctDNA, and those all pretty much were pooled into the muscle invasive group, with only one non-muscle invasive. And then when you looked at outcomes, similar to what we've been showing in urothelial bladder cancer. Again, these are pretty small numbers. The blue line is undetectable. The red line has been the detectable worse outcomes. Roger got this into European Urology with 30 patients. I've been trying to get a paper into European Urology with my data set for a year and a half with no success. I don't know what, I guess I'm not political enough to get it, but clearly there is a role for this in the upper tract, and this is a tumor agnostic. You can actually also use the tumor agnostic in the bladder patients if you don't have enough TURBT specimen, which that's a rare case. Very rare do we not have enough from a TURBT for at least Natera to be one. So bringing all this together, just some food for thought concepts that I've put together. So this is a trial that is currently was approved by Alliance Icahn and is going to go to CTEP, I guess, which is the next layer. Task force, which is the next layer, if I ever do the letter of intent, which I have to finish. The idea is that we now, I think, have a biomarker where we can allow better selection for patients that don't need neoadjuvant chemotherapy. So if you are ctDNA undetectable, I think that you probably can forego neoadjuvant chemo. And I don't think it matters what neoadjuvant chemo, because the patients do so well that it doesn't. I don't think it matters if it's EV pembro or immunotherapy or gemcitabine or whatever it is that you want to use. Again, because the undetectable with surgery alone have a greater than 95% RFS, and those patients who do have a recurrence, I think we have lots of great adjuvant therapies that we can probably rescue some of those patients. So this would be a randomized trial to cystectomy alone versus neoadjuvant standard of care versus cystectomy. And the primary endpoint being a 2-year recurrence-free survival. This unfortunately would be a large sample. It would be a large study. It would require 550 patients to show this non-inferiority that would likely take a long time. So there are some concerns with a trial design like this. But I think if we don't do this trial, then we're never going to be able to answer the question of which patients can forego neoadjuvant standard of care. The other point to this is that there's so many groups that are trying to move towards bladder sparing, not necessarily with trimodality therapy, but just systemic therapy alone and then bladder sparing. But that is, I think, a very small subset of patients. The majority of patients are still going to fall into the category of needing surgery. And I think that we should really be able to use this marker to help us better identify those patients. I am going to just talk about urine ctDNA in one slide. I think urine ctDNA or urine-based tests are extremely important. Our group has done work showing, and this was a study that was published a couple of years ago where we actually took the urine, we took the tumor, and we took the peripheral blood, and we did single-cell RNA sequencing on cells that are derived from each 3 of those mediums, and then compared all different immune lineages. We compared the epithelial cells to try to really see what can we use the blood or the urine as a surrogate to help us understand what's happening in the actual tumor microenvironment. And this is just a representative figure from that study where we looked, and this is the NK figure just because that's what I like. We can see that the urine and the tumor actually represent each other pretty darn well. Compared to the blood and the tumor. So what's happening in the tumor microenvironment from the immune standpoint is really well represented when you look at the urine compared to the blood. I don't think that's too much of a shocker, but at least in this cohort of 9 patients with really high depth analyses, we were able to correlate that. And that's the same thing that we see in the NK cells, the B cells, the T cells, et cetera, et cetera. So the urine is actually a great surrogate to help us and allow us to identify what's happening in the tumor cell itself, in the tumor microenvironment. I also just think it's a very challenging medium to work with. There are so many factors that come into play in terms of using the urine. I think you guys are absolutely doing fantastic work. Jillian has great ideas on how to be able to overcome a lot of the hurdles and the burdens that will be there. I'm excited to be able to use it. Happy to collaborate, like we spoke about. We just don't have the expertise to go forward with it. But I think it's a very important, very important to continue going forward with it to allow us to use the actual urine as a marker. So in conclusion, I think ctDNA is a promising predictive and prognostic biomarker. I think personally, from the urologist standpoint, that the pre-cystectomy ctDNA, and I hope I convinced you as well to have as much excitement as I do about using the pre-cystectomy ctDNA status from the TURBT specimen to allow us to now better risk stratify our patients, to give us better shared decision making and how to move forward. Again, we're not quite there yet. We do need to do some trials to use this, but I think at least the preliminary data is there and very promising. And so far, it's holding up, based on more follow-up and more patients. I think we can use the neoadjuvant setting as the right place to now help us de-escalate care for patients, but also escalate care for patients. I do think that in the pre-cystectomy or at diagnosis ctDNA burden, if it is very high and you give somebody neoadjuvant chemotherapy and that is not going down, those are the patients that you probably need to go to second line before you consider surgery. And that was another trial I proposed, but it's a very challenging logistical trial to put together. And I think in every clinical trial that we do, we should 100% be using at least peripheral ctDNA, plasma ctDNA, but urine ctDNA, again, with the work that's being done here, should be incorporated to allow us to now really get the data that's necessary to validate and use it clinically. And I think personally for me, I know is this being recorded? I think that, you can de-escalate your surveillance imaging, based on ctDNA, and I have started to do that with a lot of patients, especially the patients that travel long distances. And similar to Vancouver, I'm sure, I have patients that travel an hour or 2 hours to come to see me to say, oh, everything is okay, where you now can just do a home test, maybe to a televisit or whatever it may be, that will allow you to forego a lot of patient visits and allow you less radiation for those patients. Thank you, and I'm happy to take any questions.